I should also add that the topic of chest pain was always described by one of my ex-colleagues at Bennington as being the graveyard lecture. The graveyard lecture because, probably quite rightly, he thought it was quite difficult to make interesting and entertaining, and not the sort of lecture which would normally enhance one's reputation. So, anyway, I accepted the invitation with those. Actually, I told the organizer, I think I mentioned this to them. So, just a little bit of background. It's interesting that had you looked at referral patterns 25 years ago, hardly ever where you referred a patient with chest pain. Hardly ever. And if you looked at urgent admissions of older children and teenagers, chest pain was surprisingly uncommon. Whereas now, 1 in 8 emergency calls for patients aged 10 to 18 years often involve chest pain. And about 1 in 8, 1 in 10 outpatient referrals, again for patients over the age of 8 to 10 years. So there's been a change. There's no doubt that chest pain is often accompanied by anxiety and stress. And indeed, if you sometimes ask families or the patient themselves, tell me why you've come to see me, and they'll say, I've got heart pain. Not chest pain, but heart pain. So there are 1 or 2 questions we have to start asking people, patients and families, about the pain. The history is terribly important, and I'll go into this later. Does it come on at rest, on exercise, after exertion? All quite different circumstances. Where is it? Where can you feel the pain? Does it go to your left shoulder or your left arm? How long does it last? How long have you had it for? How often do you get it? Now, I often say to the children, you know, different people mean different things when they talk about chest pain. Some people mean it's a pain rather like a toothache or a headache, but in the chest. Other people mean they can feel a thumping sensation, chest, a rapid thumping sensation, which some people call, of course, palpitations, but most children have got no idea what palpitation is. You've got to be a bit specific about the pain itself. And you say, can it be severe sometimes? Does it ever make you cry? And also importantly, generally, is there a history of cardiac surgery, of course, or a history of having had the chest open for other reasons? So when it comes to chest pain, I think the burning question in referrers is, could this chest pain be arising from the heart or the nearby great vessels? In fact, this is relatively rare, but I'm going to start with it. And cardiac chest pain, of course, can be angina, acute pericarditis, and aortic pain, either due to dissection or even bruising, injury. Remember, the aorta has pain fibers. It's rather unusual, isn't it? Most other arteries actually don't have pain fibers, but the aorta does. So when it expands or gets bruised or splits, it can be extremely painful. So when we talk of angina, we have to think of the coronary arteries, which of course in themselves are also complex. But to have angina, there needs to be some obstruction or compression of the coronary arteries. There's quite a few branches, so the compression can be anywhere really, even for example, the posterior lateral part of the circumflex coronary artery. If that's compressed or has an embolus, it can produce pain. So it's never straightforward. Now, there is a universal definition of myocardial ischemia, which is a detection of a rise and or fall biomarkers, preferably troponin, which we do most often now, with at least one value above the 99th centile of the upper reference limit. And there needs to be evidence of myocardial ischemia, indicative ECG changes particularly, and perhaps imaging evidence at some stage of a new loss of myocardium, abnormal regional wall motion, or ventricular dysfunction. And of course, at the extreme end, a sudden unexpected cardiac death related to ischemia, which is one of the things that people worry about a lot, although it's exceptionally rare in children and adolescents. Broadly, the classification is one into acute ST elevation myocardial ischemia or infarction, or non-ST elevation acute coronary syndrome. So let's just look at this ECG. So a patient presents with chest pain. The troponin's raised, you do an ECG, and this is clearly an abnormal ECG. The T waves should be upright in leads V5 and V6, which they're allowed to be down in V1, V2, V3, even V4 in normal children. But this V5 and V6 inversion, marked inversion, is never normal. Also, there are T wave abnormalities, or rather flat T waves, all through the standard leads here. Most of these are not normal. So abnormal T waves there, but non-ST elevation in comparison to this child with acute myocardial ischemia who has marked ST segment elevation. You can see it here in lead 2, in lead 3, in lead AVF. AVL looks quite abnormal. This is an ST depression, and also look in V6. So this is ST elevation, myocardial ischemia. Let me just pause and tell you a short story. A 17-year-old boy, a bodybuilder with hypermuscularization, develops typical anginal chest pain while lifting heavy weights, and he presents acutely in the local casualty department. The troponin is elevated. It sounds as though it's some form of ischemia. And indeed, this is his ECG recorded acutely. Very marked ST segment abnormalities here. Not so much elevation, but look at these very, very abnormal ST segments with ST depression and very marked T wave inversion. It doesn't take a genius to say this is a very abnormal looking ECG. As it turned out, one of the coronary artery branches, a main branch, was compressed by his left ventricular myocardium. He had quite marked athlete's heart, quite severe left ventricular hypertrophy going along with this generalized muscularization. And he had what we call a myocardial bridge, and a band of muscle was compressing the coronary artery. An amazing story, but you know, he was 17 years old. Anything can happen, but the clue in this case that there's something going on was the elevated troponin and ST segment abnormalities. In general, however, of course, angina in children and adolescents is pretty unusual, but it's very important to be aware that if you have moderate to severe aortic stenosis, either valvar or supravalve or even subaortic stenosis, on exertion you can get chest pain, which is angina. It may not be quite typical of the angina that you might see in older patients, but nevertheless, chest pain on exertion in a patient known to have aortic stenosis or with the loud systolic murmur of aortic stenosis should be treated very seriously. Similarly, the patient with hypertrophic cardiomyopathy, and of course the first presentation of hypertrophic cardiomyopathy might be with chest pain. So the patient may not be known to have hypertrophic cardiomyopathy. Again, when you look at the ECG, you'll find abnormalities. Severe pulmonary stenosis by lowering cardiac output occasionally can cause angina. And then we see coronary artery stenoses, narrowing and compression, and coronary osteostenosis in patients who've had heart surgery with reimplantation of coronary arteries so that the ostium could become stenotic. For example, the arterial switch operation for complete transposition and the Ross operation, where the coronary arteries are disconnected from the original aorta and then reimplanted into the new aortic valve and root with a risk of stenosis. Not very common, but we see it very occasionally. Just a reminder that Kawasaki's disease sometimes can occur in children without the diagnosis being made, even with aneurysms, if the patient is symptom-free, and they could turn out up at a later stage with anginal symptoms caused by thrombus in the coronary artery due to previously unrecognized Kawasaki's disease with aneurysm formation. However, if they have ischemic symptoms, then the ECG will also be abnormal. We then come to some of the rarities. There is a rare condition where the left coronary artery arises from the right coronary sinus. It may take an intramural course, which can compress the coronary, that passes between the aorta and the pulmonary artery, so that on exercise, there is a risk the coronary artery could be compressed between the ascending aorta, just above the aortic valve, and the pulmonary artery, just above the pulmonary valve. Similarly, but less dangerous, but nevertheless potentially dangerous, is where the right coronary artery arises from the right coronary sinus, from the left coronary sinus in this fashion. Still a risk of ventricular dysfunction, sudden death, etc. And this is one of the things that professional athletes are screened for because there is a risk of sudden death. But the anomalous right coronary is less of a risk factor. The diagnosis of these conditions, anomalous origin of the coronary arteries, while relatively straightforward in children, once you get into the early teenage years, with all that goes with it, quite a lot of obesity, thick chest, of course, the diagnosis of the subtlety of coronary arteries then becomes much more difficult, and you might well then require to make a differential imaging, CT, MRI, particularly CT is the best way to look at coronary artery. Here's a very nice reconstruction, anomalous origin of the left coronary artery from the right coronary sinus, and giving rise to circumflex and LAD. So, is chest pain ischemic is indeed an important question. Is there anginal type pain on exertion? Is there any radiation to the shoulder or the left arm? Is the troponin raised? And are there any ECG changes of ischemia? Of course, most patients won't have ECG changes of ischemia, but once you've shown a normal ECG, once you've shown the troponin is not raised, then you can relax a bit. Now, acute pericarditis is one of the commoner reasons for chest pain, or should I say significant chest pain. It's usually viral. It's usually quite unpleasant retrosternal chest pain, which is virtually continuous. It's worse on deep breathing. The symptoms go on and off for 5, 7, 8 days. If you examine the patient, intermittently you'll hear a pericardial rub. The troponin is always raised. There's a typical ECG, and you treat the patients with non-steroidal anti-inflammatories. If you look at the ECG, it is sort of diagnostic, and here's a diagnostic ECG because it shows concave upwards ST segments. So these concave upwards ST segments all over the place on the ECG are diagnostic of the acute pericarditis. I think for the non-cardiologist and even for some cardiologists, I think this is a difficult diagnosis to make confidently. And the other thing is, if you think an ECG is abnormal, do another one the next day, because ECG changes in ischemia and in pericarditis change over a period of hours and days. Now, other types of cardiac or vascular pain include rarities. Aortic dissection. I have seen aortic dissection in a couple of teenagers with the so-called Loeys-Dietz syndrome, which is actually a kind of extreme form of Marfan syndrome, often with early symptoms, even in infancy sometimes. And with marked aortic involvement, dissection of the aorta can occur, as I say, certainly during the teenage years. Severe AV valve regurgitation. Marfan syndrome. If the patient's got severe chest pain, do they look as though they've got Marfan syndrome? Other forms of rare aortopathies. And also, you can get bruising to the vascular structures, the heart, the aorta, which can cause hematoma and extreme pain. Rugby players or people playing rugby, boxing, fighting, car accidents. Acute viral myocarditis often gives episodes of quite severe chest pain. And the relative rarity in children of mitral valve prolapse syndrome also is associated with chest pain. So let's take a break and have a bit of a story. A 9-year-old presented with this is a true story, a 9-year-old presented to my outpatient clinic acutely with 2 episodes of severe right-sided chest pain lasting 30 and 90 minutes in the previous days. These episodes of quite severe pain were separated by 48 hours. There's no previous history of chest pain described. She has or had mild flu-like symptoms. And on examination, she had quite marked right-sided intercostal chest tenderness between the 3rd and 7th rib when you examined her. Nothing else of any note whatsoever. So What investigations would you recommend? Any ideas on the likely diagnosis, or what would be your differential diagnosis? So let's think about the investigations. I think we've all agreed that for this kind of patient, you'd want to do a troponin. Troponin was normal. You'd want to do an ECG. The ECG was completely normal. The echocardiogram, which is the thing that gets done pretty early because it's easily done, also normal. And yet, this patient does have severe tenderness, intercostal tenderness, but that's it. So I made the diagnosis of Bornholm's disease, or epidemic pleurodynia. It's a viral illness. It presents with severe chest pain and intercostal tenderness, as she had. The causes include Coxsackie B, enteroviruses, influenza, and COVID. I've seen 3 examples of Bornholm disease in children with COVID. There are non-specific flu-like symptoms, and it can be infectious. In the original description, I can't remember the name of the person who described it, but it was on the Danish island of Bornholm in the 1930s. Consequently, the name of the disease, Bornholm disease, there was an epidemic among the children on the island, and this is written up in the 30s. The duration of symptoms, 5 to 8 days. The diagnosis is really from the history, the symptoms and signs. Also, there's usually a leukocytosis if you want to take blood, and viral studies may be positive. ECG, chest X-ray, echocardiograms, all normal, but it's really a clinical diagnosis from the intercostal tenderness. The treatment, non-steroidal anti-inflammatories for a few days, it all gets better. So this brings us to pain from ribs, intercostal muscles, in this group of patients. Costochondritis, where there's inflammation and pain coming from the costosternal joints, can be extremely painful. So painful it can lead to kind of psychological, psychiatric issues for the patient if it doesn't get better. And occasionally you do see patients with persistent severe symptoms for several months. Bornholm's disease, rib fractures, of course. Rib fracture, for whatever reason, will also produce quite severe chest pain. Just bruising of the ribs, bruising in the intercostal spaces, pneumothorax, pleuritic chest pain, and of course, never forget the patient who presents with malignant deposits in the chest wall, ribs, that will produce pain. So let's have another short story. A 12-year-old wakes up in bed with severe central chest pain. His parents rush him to the nearest casualty. He then gets transferred to a pediatric cardiology unit because of this severe pain. On arrival, the chest pain is resolved. He has a normal ECG, a normal echocardiogram. Troponin is negative. So let's go into the history a little bit more. The history is so important with patients with chest pain. It turns out he had episodes of this kind of chest pain before, probably 4 or 5 occasions when he was lying in bed. It tended to come on in bed, and on a little bit further questioning, if you if you have a warm drink, do you feel it burning when you swallow it? Yes, he said, sometimes. Of course, this was gastrointestinal chest pain from one of these sorts of things: gastroesophageal reflux, gastritis, esophagitis, hiatus hernia, typically a burning pain, aggravated by hot or acidic drinks and swallowing. Worse when you're lying flat in bed. Sometimes these patients do need to go and see a gastroenterologist, but they may well settle with omeprazole. The other thing to remember is that palpitations, as I implied at the beginning, may masquerade as chest pain. But for a patient who develops quite severe chest pain, it can cause anxiety in the poor child and palpitations because of the anxiety caused by the severity of the chest pain. So one of the things to question about is if people are describing a thumping in their chest and the heart going quickly, you say, what comes first, would you say, the pain or the thumping in your chest? And if the pain comes first, followed by the symptoms of palpitations, thumping in the chest, well then, you know it's unlikely this sensation is the cause of the pain itself, it's a consequence. Palpitations can, of course, be due to atrial or just ventricular extrasystoles, which are very short-lived, but nevertheless quite alarming. It can be due to other tachyarrhythmias, sustained supraventricular tachycardia, atrial or ventricular tachycardias. And the thing about tachyarrhythmias, to help you distinguish from anxiety, is that they usually begin and stop suddenly. So suddenly the tachycardia begins with the symptoms. And then when it goes away, it stops suddenly. Whereas stress-induced sinus tachycardia, with its symptoms of palpitations or thumping in the chest, occurs quite gradually, although it can come on very quickly, but it slows down very gradually. Of course, any doubts, do a Holter or ECG monitoring with a smart watch, which is a godsend these days, but do take a history. Now, musculoskeletal pain I've left to the end. It is the most common condition or diagnosis in children and adolescents complaining of chest pain. It affects 1 in 10 children at some time in their lives between the ages of 8 and 17. It's what their grandmothers would call growing pains, and she may well be right. Paroxysms of central to left-sided chest pain, but no tenderness. Usually comes on at rest when the children are watching TV or they're computing or they're just lounging around on the sofa. The duration could be anything from a few seconds to 20 minutes. The frequency is very variable. It could be twice a month, or it can be daily for several weeks or months in some patients. It's associated with periods of obvious growth. We go back to grandmother, don't we? And there can be pain-free periods for several months, but it can be severe. And sometimes you'll say to the kids, does it ever make you cry? And they say yes. So it's a real entity, extremely unpleasant sometimes, causes anxiety, of course, when it is severe, and that anxiety may then provoke palpitations. And it provokes family anxiety as well. So it's a real entity. For some people, it's quite troublesome. But examination will be normal. And I think if the history is classical and the ECG and the echocardiogram are normal, then one can reassure the patient and families, which is what people need. Quite often, once they're reassured, the anxiety goes away, etc. But the typical history, normal ECG, normal echocardiogram, and explain that this is probably growing pains from your bones and muscles, which is what your grandmom would think, and say the heart is completely normal. This pain is not coming from the heart. People need reassurance. Does anything predispose to musculoskeletal chest pain? Well, my impression is it's a bit more common in Marfan syndrome because they are very skinny and bony, and they're probably more likely to have musculoskeletal pain. Some patients with some forms of Ehlers-Danlos syndrome, patients who previously had open heart surgery with a stenotomy, they seem more prone to have musculoskeletal chest pain, and also patients with hypermobility syndrome. So, getting towards the end, so general aspects. Chest pain is common in children and adolescents and from 8 to 17 years. Most children with chest pain don't have a cardiac condition. The etiology is often evident from a detailed history, and that's important. And examine the patient. So many patients don't get examined these days. I can't believe it. Take a history, the description of the pain, the duration, the frequency, the site, the radiation. All these things are important because they point you to the correct diagnosis. Does it occur at rest, during exertion, or is it rest and exertion? Sometimes I say, well, sometimes if I'm running, it comes on, but quite often I'm doing nothing. Or does it always follow exertion and not actually associated with it? Is it associated with palpitations, thumping in the chest? And how long have you had it for? Days, weeks, months? Investigations again depend on the history, but troponin in the acute situation. Most patients get a routine chest X-ray and echocardiogram, and rarely required, in my own experience, is Holter monitoring, cardiac CT, MRI, exercise test, or chest X-ray. It's surprising how rarely I request these as part of the investigations. So that's a whistle-stop tour through chest pain, which can be a worrying symptom, and some of the potential diagnoses are also worrying, but thank you very much for your attention, and I hope I haven't finished too late, which I probably haven't. Thank you.
Thank you very much, Dr. Rigby. No, you are not late at all. I think we can open up to some questions. I see that there's a
questions. Feel free. Speak as loudly as you can.
Sarah Cook.
Yeah, thank you so much. Sorry. Hi, Dr. Rigby. Thank you so much for a really wonderful talk. I just wanted to ask two questions, if possible. The first being, you mentioned about troponin and that it should be above the 99th centile. I've found in my experience, the reference ranges for age and sex in children is quite a wide range. Is there a specific data set that you would use as your reference range for the 99th centile?
The range of troponin?
Yeah.
Well, I'm sure there is some data, but I tend to take the view if the troponin is raised, even if it's just a small amount, you've got to take it seriously. So I think that is the best line to take, and not be looking at graphs of levels and think, if the troponin is raised, it's raised. If it's not raised, it's not raised. So I think that's always my approach. If it's raised, it's significant. If it's normal, let's just take it as being normal.
So, for example, just to point out, the adult reference ranges are not the same as children's. So would you be using the life data for that, or?
My speaker's not working very well, or picking you up. Say again.
Oh, so sorry. I'm moving a little bit close to the screen. Hopefully you can hear a bit better.
Yeah.
The adult troponin reference ranges are not the same as children, obviously. What would you recommend using as the appropriate pediatric data, or would you recommend using the adult cutoffs in an adolescent range?
I can't. I mean, there are chapters in books which on chest pain, some of which are written very well and some which are not, what have you. I can't recall seeing anything good in the last decade.
Yeah.
So, in which case, I hope my lecture has been quite useful for you. I think there was a publication in Archives, and I can't remember the name of the author, dealing with chest pain, although it was weak on the cardiac front, but quite strong on the respiratory and chest front, although there was no mention of Bornholm's disease. I think, the message, in a way, about the chest pain stuff is it ischemic? Well, you can tell about that from your ECG and your troponin and what have you. And is it potentially dangerous? Again, it's just the ischemic types which are dangerous, really. And and if you've got acute pericarditis, which is very painful, then the troponin goes up, but it always gets better. So I think it's one of those things you've got to start using your common sense. I mean, there's nothing wrong with reading, and indeed, I'm pleased to hear you talking about reading, because people seem to read less and less these days. But a bit practical common sense, I think, is a good idea.
Yeah. Okay, thank you. And then I just wanted to ask one other question. Could you explain how coronary dominance would affect risk profile in anomalous coronary origin? Because obviously most people are right coronary dominant. And so in that setting, would it still be that the anomalous left from the right is the most dangerous?
Yeah, it's an interesting topic. And it is, as you imply, it is true that some people have one coronary artery considerably bigger than the other. I mean, normally the left coronary artery is bigger than the right because left ventricular myocardium is more extensive, and therefore you need a bigger left coronary artery. But we do see patients with a dominant right coronary system, a large right coronary artery, smallish left coronary artery system, and then the right coronary artery supplies not only right ventricular myocardium as well as part of the left. However, those patients who've got any kind of coronary compression from the anomalous origin that I showed, those patients do tend to have dominance of the other coronary arteries. So if you've got an anomalous left, whereas there's always been a bit of compression, even though it may have been symptom-free, the right coronary artery automatically becomes rather dominant, although not profoundly so, but it tends to be a bit bigger than the left. Probably a consequence of the chronic compression. But
yeah, I was thinking in relation to the posterior descending artery supplying the AV node in the inferior wall, how that would impact that ischemic profile.
Yeah, I mean, it is true that if you've got anomalous origin of the left coronary artery from the pulmonary artery, for example, in that circumstance, then the right coronary artery is very dominant and supplies, particularly in patients who escape significant symptoms, then the right coronary artery from the normal also supplies the territory of the left coronary artery, and then you get shunting into the pulmonary artery in retrograde fashion. So, so dominance of coronary arteries is kind of complex. Sometimes it's useful to have a very dominant system, particularly if you've got this situation of Al Kappa. But that's different from here. These patients with Al Kappa are not presenting late with chest pain, often in exceptional circumstances.
Yeah, of course. Thank you so much. That's really helpful. Thanks for your talk.
Thank you.
Fabulous. Do we have any other questions from the audience? No, not yet. I don't think so. I think also, I think with the resources that you were referencing, Dr. Rigby, there is that there's a 15-minute consultation with a sort of structured approach to chest pain in the archives, which is not as cardiac focused, but I think having had a quick search more recently, they've also had a 2024 publication that seems to focus a bit more on excluding cardiac causes of chest pain. So if anyone is looking for specific resources in a kind of quick fashion, those are available through the archives.
What you find sometimes written is opinions rather than fact. And it's interesting if the condition which has become known as POTS syndrome, which is not characterized by chest pain, but postural orthostatic tachycardia syndrome, which can occasionally in teenagers produce profound symptoms. If you look at online at the Cleveland Clinic big document on advice on what to do, and the advice then is, if you develop symptoms, immediately phone your cardiologist. Which is the last thing, because this is a non-cardiac condition. It's a non-cardiac condition, which probably somebody else is best treated by psychiatrists and psychologists. And the last thing that you want to tell the patient to do is, if you develop symptoms, ring your cardiologist immediately, emphasizing again that you've got a problem with your heart and it's not a cardiac problem. So that's an example of don't always believe or agree with what you read online.
Absolutely. I think you have some claps there. I think we do have just one more question as well. So would you advocate for testing troponin in most presentations of chest pain, as this is not often done in my experience? And that's come through in the chat.
Any acute pain, so the person who turns up brought in by an ambulance or brought in by the family with an episode of chest pain very recently, then I think in that circumstance, to do a troponin actually can be very useful and reassuring. For the patient who comes for a consultation with a 4-month history of intermittent chest pain, then of course there's no point doing a troponin then. So I think it depends, again, it's the history, isn't it? The history and the examination. But recent chest, very recent, within the last half an hour or so, chest pain, then it's worthwhile doing a troponin.
Thank you. And just a last question from me, just related to the troponin topic. Would you, in sort of those cases where the initial troponin is normal, but you're not suspecting a kind of cardiac cause of the chest pain and the ECG is normal, would you be advocating for serial troponin measurement? So obviously in adults, oftentimes if one troponin is done, then another one is done a few hours later.
I think if you've got a very, very borderline troponin at the beginning, well, obviously then just repeat it to see what it looks like even an hour later, because you may find it's clearly raised or clearly low. So sometimes in borderline cases, yes, having a repeat troponin is worthwhile. But if it's clear cut, you don't need to keep repeating. If it's clear cut, you've got a diagnosis of myocardial ischemia. It's up to the cardiologist to sort out why.
Right. Thank you. Okay. Amazing. I don't think we have any other questions, but thank you so much, Dr. Rigby, for your talk. This was really very useful.
The invitation to give the graveyard lecture.
Just for all attendees, you should hopefully be receiving a survey shortly just on our teaching, which we'd be very grateful if you could complete. And if you could also just register your attendance via MedTribe, that would be fantastic. And our next teaching session will be in July on the 15th, and the bookings will be made available for that shortly via MedTribe as well. But thank you very much again, Dr. Rigby, for your expertise.
Well, have a good day. Bye.
Thank you.